Hello, everyone, and happy Pride Month. My name is Heather McPherson. My pronouns are she and her, and I'm the president and CEO here at Women's College Hospital. Before we begin, I would like to acknowledge that the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Today's panel will explore themes of intersectionality and the differences members of the 2SLGBTQIA+ community experience in healthcare in the GTA and beyond. Here at Women's, we strive every day to ensure that healthcare is equitable for everyone and to create a place where everyone feels safe and recognized. Over the years, we've seen this commitment manifest through the evolution of our electronic health record to include preferred names and pronouns, gender-inclusive washrooms, and cultural competency training for staff and physicians. We take immense pride in our leadership in our transition-related surgery program, which extends beyond surgical research and innovation to include comprehensive community support and education. We are also ready to launch our new strategic plan, which includes the creation of Canada's first Centre for Sex and Gender in Health, with the aim of addressing sex and gender bias and gaps in healthcare and in research. Speaking of strategy, I'm pleased to introduce today's moderator, the Vice President of Strategy, Quality, Risk, and Privacy, Jack Woodman. Since joining Women's College in 2012, Jack has played an instrumental role in delivering on our healthcare revolutionized strategy and innovative solutions to meet unmet healthcare needs in communities facing barriers and inequities. Thank you, and over to you, Jack.
Thanks, Heather. Hello, everyone. Happy Pride Month. I'm Jack. My pronouns are they, them. I am queer and genderqueer, and I am so honored to be moderating this esteemed panel on 2SLGBTQIA plus intersectionality in healthcare today. Of course, I cannot speak to intersectionality without noting critical race scholar, activist, and feminist Kimberly Williams Crenshaw, who coined the term intersectionality, setting the stage for more nuanced conversations about diversity and giving voice to millions of people whose multidimensional identities weren't being taken into consideration. Intersectionality in healthcare is so important because it factors in all the dimensions of an individual and how those factors affect care. Crenshaw noted that intersectional experience is greater than the sum of racism and sexism, and any analysis that does not take intersectionality into account can't sufficiently address the particular manner in which individuals are subordinated. For example, there are times when a person might be discriminated against for being a woman, for being Black, being pregnant, being queer, or all four factors at the same time. So today we're going to discuss queer intersectionality and health experiences and think about what we're doing well and where we can improve. With that, I'm going to introduce our three incredible panelists. First, we have Leslie Lee Kam, a Rainbow Senior, who is also the co-chair of the board of Pride Toronto. We're joined by Dr. Chase Everett McMurren, who serves as the Indigenous Health theme lead in the MD program and the Indigenous Practitioner Liaison within the Office of Indigenous Health in the Temerty Faculty of Medicine at the University of Toronto, Chase, and Dr. Laura Stratton, who is a family physician here at Women's College Hospital and a lecturer in the Department of Family and Community Medicine at the University of Toronto. So to begin, I'm going to toss a question out to everyone and ask you to tell me a bit about yourselves and how your life experiences have brought you to be on this panel today. And a nod to Leslie first, please. You can just take yourself off mute first, Leslie. Thanks.
You would think after all these years, I would know better. Hi, everyone. Thanks to Women's College Hospital for having me on the panel today. So since we are talking about intersectionality, I like to do a little rhyme that says, I am the epitome of diversity and intersectionality. I am a Rainbow Senior, proudly 70 years old now. I never thought I'd live to be this age, given the trials and tribulations and challenges that we face as Rainbow folks, especially as we get older. My main focus of work now is improving and saving our lives being the lives of Rainbow Seniors, and also doing intergenerational work with Two-Spirit, queer, and trans youth.
Thank you. Chase.
Tansei, Atum Scottowan, greetings. Hi, everyone. I'm so honored to be here. And really wanting to acknowledge how lucky I am to not need to think about being a queer person. I'm just me, and really grateful to be that way, which is not the case for other people in other times and places, even within the city itself. And so the ability to simply be myself is something that I think I might take for granted most of the time. And so wanting to celebrate that and the reality that I'm a physician because I wasn't ready to be queer. Going to medical school was a great way to leave Southern Alberta and find time and space to actually realize that I'm a homo. So grateful for that. I didn't put that in my med school application letter, though I've been in practice long enough that I can admit that now. So thanks for having me here.
And Laura.
Hi, everyone. So I'm Laura. I use she, her pronouns. I'm also a parent to a 19-month-old who has so kindly decided to share this virus, hence the very raspy voice. And so hopefully it lasts throughout today's panel, and hopefully everyone can hear me okay. But I'm here as a queer family doctor. I was lucky to do some additional training after my family medicine residency in 2SLGBTQ Health. And so as part of my family practice here at Women's College, a large percentage of my population falls under that umbrella. And I've tried my best to commit to improving the care of this community that I'm part of, and including education to residents and learners.
Thank you all. Well, we know that 2SLGBTQIA plus communities have different experiences and certainly not always better experiences with healthcare in Canada than many other communities. Could you share a little bit about your experiences and how intersectional identities might play a role in that? And I'm going to start with Chase on this one.
And ask Omitan, thank you. Big question. So again, I'd like to admit my privilege that I've generally had a lot of ease being a cis white passing male person. And so in my own experience, I've gotten by quite okay. And at the same time, when I think about healthcare experiences, I can see the many things that I take for granted, particularly things like health literacy, being able to read English with ease, having eyesight, like those things that I don't typically think about are just like the bare minimum in entering a hospital space or navigating the confirmation of an appointment or checking in, et cetera. And so I think there's so many in order tos involved. I like thinking of them as IoTs. And slowing down to think about how many in order tos are required for, say, a person clinically, a patient, person, human, seeking care, for them to realize a recommendation in a way. It's not as easy as writing a quick prescription, that there are many in order tos to actually get to the point of the medicine doing its job, hopefully, and many conscious and unconscious layers as well, including whether the practitioner seems hopeful and confident that the medication will work. And so I bring that up because I think for people who maybe experience the health system with some mistrust based on historical and current realities, for example, like overt racism in emergency rooms or recent forced sterilization. There are good reasons for Indigenous folks to be a little bit reticent about seeking healthcare, and quite heartbreakingly, it's not uncommon for people to feel blamed when they do eventually seek care because they present with significant complexity, perhaps because they haven't received preventive care or measures that would have maybe nipped something in the bud. And so I would say in this moment, and then I'll stop talking, that one of the things I hate hearing most is the question, why did you wait so long to come? I can't think of something more shaming and unhelpful, and yet I've heard it so often from colleagues and trainees who say that, and I think they say it unskillfully because they're overwhelmed. So they're saying it because it's like, oh my gosh, what am I supposed to do with this, whatever, fill in the blank, and yet don't realize what they're saying and how harmful that can be. An alternative, if you're wondering, is thank you for coming in. Or like, I'm so glad you came. Let's take it from here. Shall we? So just wanting to put that out. If there's nothing else from today, I'm glad that that came into my mind because I think it's a way to change practice and in a healing sort of way.
Oh, thank you so much, Chase. It's so great for you to frame that so eloquently, because the aspects of trust and harm that have occurred to many communities, many individuals in healthcare are so significant. And often as providers, we can forget how much impact we have in just those words. Leslie, would you weigh in, please?
Well, for me, as you can see, I'm a woman of color. I am a woman. I've already been misgendered twice today when I was out in the world, so that's something else that happens. And this is Robin, my mobility device. So being differently abled is also a negative for me. My age causes a problem. As Chase was saying, I have a lot of privilege in terms of having English as a first language, and I've had to learn how to navigate the many health systems that have become challenging for many of us. I am out everywhere I go. I identify as a dyke, and I'm wearing my human t-shirt for a reason, because people forget that first of all, we are human beings, if nothing else. And that is something I constantly have to remind people about. So when I'm receiving healthcare, it's on all these different intersectional levels where I'm advocating generally for those of us who don't have a voice, and then for myself. And the other point I want to raise is seeing how trans folks are being treated in healthcare systems, because the transphobia is so rampant. And a trans person going in to receive healthcare, some folks can't hide. You know, it's apparent that they're trans. And you have to deal with transphobia when all you want is good healthcare, even something like an open wound. And I've been with a friend who has gone in with a cut on her hand, and the transphobia she received when she's bleeding. And I'm saying, just do something for her hand. And they're saying, well, are you a man or a woman? That is not the point. So these are all the things we have to be mindful of when we're talking about intersectionality, as it affects people's real lived experiences in healthcare systems.
Thank you, Leslie. And that was a really powerful example, and one that is unfortunately all too common. People receiving care, and we're working, at Women's College Hospitals towards trans competent care, and I think a lot of organizations are, because sometimes providers are even don't have a full understanding of what the difference would be when somebody is seeking gender affirming care versus they're just seeking care. And when they're just seeking care, what we need is competent care for folks. So thank you for that answer. And Laura.
Yeah, no, I think some very insightful and important points highlighted already, and just wanted to follow up on Leslie's comment about when kind of trans or gender diverse patients or individuals going to seek care, like often having at times to sometimes prove your transness in order to access care and convince healthcare providers that you're deserving of gender affirming care. But then on the other side of sometimes having to try to hide your transness in order to access the care that you deserve and need. And so sometimes depending on the healthcare environment that you're in, choosing kind of what identity to display or show, if you have that privilege to sometimes hide or show that identity. Sometimes, or a lot of times, there's differences of identities that you can't as easily hide in terms of age or race. And so sometimes when you're seeing a healthcare provider, sometimes you're kind of put into this box of whatever that healthcare provider sees you as. And then you're kind of stuck in that label or box, and then not getting access to the care that you need and deserve.
Thanks, Laura. Yeah, it's interesting, the environment of late, because we're now, looking for equity data. So there are, surveys in every healthcare organization across the province where we're asking people very personal identity questions for the purpose of improving their care. And yet sometimes this can be very delicate because these are folks, we are folks who have been harmed in medical care settings. And so then providing that information to an institution, can be very frightening or have its impacts. And so one of the other things that is a big piece of work here is around data justice and data sovereignty, who owns the data, but thinking about those hard questions as providers about, why are you asking identity and what does that mean for individuals? Leslie, I know you are an advocate for Rainbow Seniors. Thank you. Your work through Pride Toronto, long-term care homes, and other organizations in the GTA. Can you tell us a bit why you feel advocacy for Rainbow Seniors is particularly important at this time?
Well, actually, it's more than important, Jack. It's crucial because it's gotten to the point where if we don't have this recognized way of working with Rainbow Seniors, we are going to die. And for me, it's also intergenerational because the same thing is happening to queer and trans and two-spirit youth. And people don't make those connections. So the reason I became an advocate for Rainbow Seniors is because when I was designated as a junior senior, I was in a rehab hospital for about 5 or 6 months. I just come out of a coma. And because I'm an out dyke, I identify as a dyke, and I was in a rehab facility undergoing extensive occupational and physiotherapy. And there were 2 PSWs who were on the night shift who left me in my urine and feces. And when that happened to me, that woke me up, because when I came out of the coma, I did not know what I was going to do with my life. And when that happened, I made it my mission and my purpose. So that was 2007. So 17 years later, I said, no, I did not want another Rainbow Senior to go through what I went through. And that is why I started advocating for Rainbow Seniors. And as I said earlier, the example I used about how my trans friends are being treated in healthcare systems, I also advocate for better trans care in healthcare systems. And it's really crucial in terms of improving and saving our lives, because so many of us are afraid and we are hiding in long-term care homes, we're hiding in retirement homes. And even the word queer that is used so commonly and widely today It's very difficult for us to hear that word because it was used as a weapon against us. And what people fail to realize is that we are all covered under the Human Rights Code. And people are using, healthcare people are using religion as a weapon against us. And they have to remember that they're human beings too. And would they want to be treated, you know, the way they treat some people in the name of religious beliefs? So in terms of intersectionality, all of these different oppressions are all woven together. And I've made it my mission and my purpose to put a stop to that. And that we look at how we treat each other. And it comes down to treating each other with kindness, caring, compassion, and respect.
Important values. We talk about gendered ageism here at Women's College, and you know, a lot of that conversation has been around women, you know, experiencing sexism and ageism, but it also, of course, in a big way, plays into across all genders, recognizing there are more than just a binary of men and women in gender, and that the ageism is really rampant in this community. Through your work, what kind of progress are you seeing, and do you see a positive impact on the Rainbow senior community that you would be interested in sharing?
Well, yes, now great strides are being made. I'll use an example of REKAI, REKAI. It's the only long-term care home in the world right now that's completely rainbow inclusive. And they have devoted an entire wing of 25 beds to rainbow seniors. They're located in Toronto. And they're opening a second location where they're going to designate 34 beds to rainbow seniors. And the word has spread far and wide. There are 800 folks, rainbow seniors, waiting to get into their location. And that's really important. The other thing that's happening is that the city of Toronto manages 10 long-term care homes. And I am one of a team of many rainbow seniors, plus other organizations in Toronto like the 519, the Senior Pride Network, Sherborne Health, Rainbow Health Ontario. We have developed a toolkit called Leading and Learning with Pride, where we are educating the staff that work in these 10 long-term care homes that are managed by the city. And it's mandatory, I made sure that happened, that all staff are going to be trained in terms of rainbow education and how to work with us. So that's another huge plus. And just Saturday of this weekend, just gone, Pride Toronto, we just celebrated our 4th annual Pride Toronto Rainbow Seniors event. And Buddies is also now, I do an intergenerational youth elders program at Buddies, and we just celebrated a Rainbow Senior Showcase. So we are having fun, even though there's protesting and, you know, and education and awareness is still important for us to celebrate our lives and what we have contributed to making sure folks like yourselves here today are here today.
Yeah, your intergenerational approach is so impressive, and I've seen your work at Buddies, and you know, it's really fantastic, and so much community engagement as part of that you're leading. And it's, as you said, it's a crucial piece when it comes to improved healthcare outcomes for Rainbow seniors and all 2SLGBTQIA plus communities in Canada. Why do you think the community engagement piece is so important in this work?
You know the saying, not about us without us. So that's why it's so important. And when you start bringing people together, great ideas surface. And diversity, you know, these buzzwords now, diversity, equity, and inclusion. you have to bring those things to life. Those kinds of discussions have to be more than just something on paper or intellectual and academic discussion. So having actual events where folks can come together and chat. For every time we've had our Rainbow Seniors event, we've had Rainbow Seniors coming out. We've had seniors who show up and come to us and say, I am one of you, but I didn't know how to verbalize it. I didn't know what the language was or the words are. And these are folks who are in their 60s, 70s, and 80s. Part of our Rainbow Senior Showcase, we had somebody who was in her 70s who just transitioned. We had there 2 men who just transitioned and they're in their 50s. And what they're telling us is, because there's community engagement, because they're seeing, people, younger folks interacting with older folks, conversations are happening. And that is how positive change happens.
Mhm. Thank you, Leslie, and thank you so much for your work and for sharing that with us. I want to note if people want to use the Q&A function, you can do that to drop questions into the chat as we're going forward. And I'll probably come back to you, Leslie. I could listen to you talk all day. I'm gonna shift over to Chase. And Chase, we're really excited to hear about your role at the U of T Temerty Faculty of Medicine in the Office of Indigenous Health. First question here is, can you speak about the importance of learner support and resilience on the impact of access to culturally safe care? And you can toss in there anything you think can be done to improve education for learners as it relates to Indigenous and queer people.
Yeah, thank you. So I think I'd love to flag the word resilience.
Yes, I thought you might.
Yeah, so in my privileged work as a medical psychotherapist, I've made an effort to become less of a word police person or tyrant, and yet I'm often very mindful of the words we use and how we use them, why we use them, where they came from. And the word resilience is a challenging one because it celebrates people persisting or finding ways through difficulty, which is great, right? Life is hard. Like, we're here to suffer and to grow and learn and also have pleasure and joy. Like, I think I'm fascinated by the idea of the pleasure pain principle, in the sense that, like, we can't have pleasure without pain. They're part of the same circuit. Anxiety and excitement are the same thing in the nervous system, though they're registered by parts of our nervous system differently, etc. So I think I'll get to your question, I swear. But I just think this idea that life is suffering, right? And some people have a lot more suffering than others, or it shows up in different ways. And yet, as Leslie mentioned, we're all human, right? And so whether we're billionaires or we're currently unhoused, our physical experience is probably quite similar, right? We might think it's different, but we're still embodied and having sort of experiences as humans, even though there's lots of intersectional kind of variation there. But to resilient, so the reason I bring up resilient is that it celebrates people putting up with the status quo, much the same way that I'm reluctant to use the expression differently abled these days because of some of the reading and learning I've done around disability justice, and this idea that people are disabled because the system is disabling them, right? They're fine as beings, they can get by, but the system itself is not able or willing to accommodate, much the same way that our health system is set up in a very particular way. A lot of people don't necessarily know. I think the surgeon's name was Halstead, but the person who came up with the residency training program for physicians in Baltimore at Johns Hopkins made it possible with cocaine. He had a strong, important relationship with cocaine so that he didn't have to sleep as much, and he expected the same of his trainees. And so when we think about the culture that we're in and medical cultures, et cetera, it's based on this, that you might need some stimulants and might need to make some sacrifices to get the job done. And that's challenging. So when we think about resilience, we're celebrating that people have kind of put up with and made it through. And I think it's important to consider, like, why did they need to do that? Or what were the conditions in place that required them to be so resilient and be celebrated for how hard they worked or what they endured? And so kind of the idea of shifting or looking upstream, perhaps, if we want to use that metaphor to sort of see, like, well, uh, what happened? Like, how did we get here? So where we are in terms of Indigenous health, wonderful things are happening slowly and surely. There's a slow trickle of Indigenous medical students in the program at U of T. I am so excited that they want to come, and I'm also shocked when people want to come to Toronto, especially if they grew up in rural settings in other parts of the province or in what we call Canada. So when they do come, I'm delighted and curious. And sometimes it's because they're interested in a very particular type of medicine, or they might have a family member here. Though it's interesting, right? Because I don't know that the default place to go for Indigenous rich training is downtown Toronto. That said, there's about 100,000 Indigenous people who call Tokorondo or Gitche home, which is way more than the census. And that's another conversation. So we don't need to get into that now, but the census says there's about 20,000 Indigenous people, and yet there's probably about 100,000. And if you know how funding models work, you might wonder about budgets and what that looks like for Indigenous folks in Toronto. So good things happening. I kind of forget the original question, though I'll just riff on it briefly, that I really do think that it's a cause for celebration for an Indigenous person to get into medical school. I think it's a cause for celebration for anybody to get into medical school in Canada. It is a feat, and most have to sell at least a quarter of their soul to someone or something in order to get in. A lot of sacrifices made, and personality shifts that happen in order to, like, get through the crucible of getting into medical school. At the moment, for an Indigenous person to get into medical school, it is like mind-blowing with the reality that less than 50% of Indigenous youth graduate from high school. So that's the reality at the moment. So to get from high school to the doors of a medical school is a like out of this world accomplishment. I think one of the challenges is that once they get there, often Indigenous students are afraid of identifying as Indigenous, or are really cautious about it because many assume that they just got a free ride, or that they sort of showed up and were let in because they're Indigenous, which is not at all the case. And is really challenging, right? Because of the models of meritocracy. I can't directly quote evidence for you, but it wasn't that long ago that at McGill, there was huge pushback and the threat or maybe reality of lost alumni support when more spots were dedicated to historically and currently oppressed folks, because donors wanted their kids to get in because they worked really hard for it. And so if we think about how pervasive that sort of, like, I worked hard and you could have what I have if you worked hard too approach is really, really pernicious, I think, and really challenging, and something that I struggle with in a medical model, because in order to get into medical school, again, people sacrifice a lot and develop habits with or without cocaine, a la Halstead. But it can be hard, I think, for some physicians to relate to patients because the way of being is just so different, right? The idea of needing to pee isn't available, where it's like, there's no time for that. This surgery's 7 hours. Like, I'll hold it and I won't drink any water. So when someone comes in experiencing another phenomenon, it can be difficult to relate because it's like, what? Like, why wouldn't you just this or that? So I'll stop there. I don't know if I answered the question, but I hope I offered some food for thought at this lunch hour. Hope people are eating.
Going to switch it to off mute. And I know you're somebody who understands cultural humility in healthcare, what we mean by that. Can you tell us a bit more about, can you frame it in terms of what it means for you, and if you think cultural humility can be taught to future healthcare workers?
Yeah, Sure. And I'll try to be quick because I don't want to take up too much space. So the root of humility is hume, which is like dirt or earth. And so I find that helpful that we're all dirt, right? And we are made of carbon. We're all just in these bodies unknown to us, in my opinion. Um, and and that we're part of the earth, right? We're these beautiful electrical systems that are absolutely interconnected with everything else, and also none of it belongs to us. Right? Like our body's not actually ours; it's on loan to us, I think. And depending on our death practices, hopefully we'll be good compost when we're done. Humility, though, is interesting because it's in conflict, I think, with what parts of us and parts of other people expect in physicians. And again, I apologize for my physician centrism here. We can extrapolate, I think. This idea of going to somebody and them having answers or like knowing what the hell they're doing. I think that's a big part of it, right? We want competence. We want people who are confident and know what they're doing. And we also want people to be humble and know what they don't know. And so that can be challenging for medical learners, and all of us, I would say, to negotiate that, right? Where it's like, how do I be confident and also really humble about it at the same time? It's a bit of a paradox, I think. What I do know is that when I think about the definitions of cultural humility, it's acknowledging that I can't know the lived experience of somebody else. It's an impossibility for me to know what someone else's experience is because I'm not them. Right. And when I try to pretend that I am, or say like, I know what you're feeling, or like, I can relate, not helpful. Right? And it's interesting, especially when we think about tendencies among different populations. It's not uncommon for people to actually try to relate by connecting or like finding a similar experience and sort of comparing notes. But in reality, that's often not very helpful. It's hard for people to sort of experience that as kindness. But when I think about cultural humility, I think the idea is acknowledging that like culture is everywhere, and each of us is part of a bunch of cultures and subcultures, right? Like medical culture, culture at women's college, culture at the University of Toronto, Toronto culture. Like there's all of these subsets that are hard to kind of actually define in a way. What I find really fascinating is thinking about the culture of my families, right? Like the way that my family celebrates holidays and which holidays it celebrates and which calendar it follows. Those things are often just assumed, right? That everyone's following a Gregorian calendar and that like everyone's taking a Christmas vacation that's very Christianized and colonized. And so being culturally humble is the idea of just acknowledging that, like, wait a minute, this is one very specific lens. And it seems like it's normal because it's predominant and it's sort of got the like dominant narrative spot for now. And at the same time, there's so many other narrative threads that are alive and well, that we maybe just don't have the privilege to know much about or didn't have the awareness to ask. So to make it clinical, I think that idea of just holding people, not just holding people in high regard. So lately I've been playing with this concept of like regardful care. And we could say culturally regardful care if we wanted to add a word. The idea of seeing someone as a beautiful human being who is eminently wiser than we are about their life, right? So we might have some clinical expertise or we might have an outside opinion about what they should do. But again, should is a swear word. They could do it if they want to. But I think having deep respect for people and where they are and how they are, that for the most part, even when people are doing things that we abhor or think are awful, being able to pause and sort of be curious about what purpose it's serving.
Mm.
I don't think we ever do anything without some kind of purpose. It might not be conscious, but we're still trying our best to get by. So final thought, there's this fun word, and the word is ultra-crepidarianism. And I just love it because I think it makes me sound smart. Ultra-crepidarianism, which means giving advice in a domain in which we do not have expertise or something. I'm paraphrasing. But I think that we're all ultra-crepidarians whenever we give unsolicited advice or anything kind of out of our lane about what people should do or how they should do it. It's probably none of our business, right? And if we do think it's our business, I think we do everyone a service by slowing down and getting permission before we give it. So I made it a habit years ago that before I give a recommendation, even something that feels really benign clinically, I still make a habit to say like, I've got some ideas about fill in the blank. and I'd love to share them with you. Is it okay if I give you a sense of kind of what I think might be helpful at this time, or something like that, so people can at least orient to the idea that they can say no thanks, go to hell, or like you don't know what you're talking about. Giving people that opportunity, I think, is a sign of deep respect.
Yeah,
And breaks
wow,
the
that's very valuable. It's almost like you're inviting consent in a different way that that gives that to the patient to have the opportunity to consent to receive that care. Let me see. I think I have another question for you, but I'm gonna move on to Laura this this round. Don't count that question out yet. Okay, Laura, if I can ask you, we know that you also work with a large population of trans and gender diverse patients in your practice as a family doctor. Could you share some of the differences you see in the healthcare needs of the community you see? And yeah, we'll start there.
So I maybe feel a little ultra crepidarian, to use Chase's new word of the day, for me anyway, in giving maybe advice about a community that I'm not part of, but in terms of the broader 2SLGBTQ community. In terms of differences in healthcare needs, I wanted to highlight that I actually think that some of the healthcare needs are actually very similar. And so when we look at the actual fundamental basic healthcare needs of the trans and gender diverse community, which is so broad and diverse, I mean, the name diverse is in the trans and gender diverse, that the healthcare needs in terms of primary care access, preventative care, so cancer screening, chronic disease management, high blood pressure management, mental health supports, those are all going to be very similar healthcare needs compared to cis populations. And so I think overall, there are more similarities than differences. And thinking about, again, with the diversity within the community. So if you think of a 65-year-old trans woman versus a 20-year-old like non-binary neurodiverse individual, they're going to have very different healthcare needs. They are both going to be part of the trans and gender diverse community, but their healthcare needs are actually probably going to be more similar to that of their cisgender counterparts than they are to each other. And so I think it is really so varied and at an individual sort of level with different identities in terms of and needs that are going to be the case. What we do see, though, in terms of differences, though, are that access to healthcare. And so we know there's an issue in terms of health inequities, where trans and gender diverse individuals in general typically are not getting these healthcare needs met. So even though those healthcare needs are very similar, these needs are not being met. And we see that from study after study that there are so many barriers in terms of accessing care. The system is not set up in a way to meet these basic healthcare needs, that the patients are having to do a lot of self-advocacy, again, having to prove their transness, having to educate their healthcare providers, having to do a lot of do-it-yourself and learning from within the community, or going to Reddit to learn about how to access care or how to get the care that is deserved. And so a lot more teaching of healthcare providers and advocating for yourself to get that care.
Thank you. It's made me think about, we recently conducted a community voices study, and that included in-depth information and feedback from queer communities, and particularly trans and gender diverse communities. And the loudest thing that came out was challenges to access primary care for folks, because finding a primary care physician who feels comfortable and competent providing a full scope of primary care has been challenging. So we've been hearing a lot. I mean, of course, we heard about that in the TransPulse data early, and this is reinforcing that information. So, and we're certainly striving to create more safe spaces for queer communities in healthcare here at Women's. Do you still feel that there are barriers in place that might adversely affect healthcare professionals from providing the best care for queer people? And how can we start to remove those barriers? What is needed so that we can open up greater access and have more professionals that feel comfortable providing care?
Short answer is yes, there are absolutely barriers. I think it depends how much time we have left to kind of go through all the barriers and try to solve some of these barriers and access to care. The other point that I wanted to make and bring up as you were talking was about just also gender affirming care, where that access to care, where healthcare providers sometimes not feeling comfortable or competent providing trans affirming care. As soon as someone asking for anything trans related care, as soon as the word trans is there, then it's like, okay, I'm going to refer to someone else. I have no idea how to support you or even where to begin. But we actually do a lot of gender affirming care already within healthcare in terms of cis populations. And so in terms of hormone therapy for postmenopausal individuals, for hirsutism, so increased hair growth, in conditions like PCOS, we use hormones and are very comfortable in prescribing that, or surgery for breast reconstruction after mastectomy for breast cancer treatment. So there already is a lot of gender affirming care. And I think we sometimes end up viewing trans affirming care in terms of gender affirming care as being something different. And I think there are obviously nuances and differences, and there is that lack of education that's slowly improving in terms of the care education that's happening in medical school and residency in terms of providing care specifically to trans individuals. But this is not so wildly different than stuff that we're already trained on. And so it's just overall kind of improving that access to education, making it standardized within the curriculum. Right now, a lot of learners are having to do their own kind of self-learning as well, and advocating also for trans care to be part of curriculum. And so we're seeing some improvement in terms of education within the undergraduate medical education system, but there still isn't really anything standardized across the province, across the country, in terms of what is the standard of care look like? What is it that every medical student or every resident needs to know before they graduate? And so it's quite piecemeal, and where on an individual healthcare provider level, having to do a lot of that training and seeking out that education in order to provide that care, versus there being a kind of a standard basic level of care that all healthcare providers should and need to know. So in terms of trying to improve some of these barriers, like the education piece, and also within that education piece, not having it so siloed where it's just this half-day topic on 2SLGBTQIA plus health. It needs to be integrated within the curriculum. And to Chase's point about talking about cultural humility and teaching about cultural humility, that's going to be kind of encompassed throughout various topics, and not just within trans care or Indigenous health or Black health. We want to kind of integrate this education across the curriculum, and not just as isolated, siloed areas of education, just so that it's not seen as this separate other thing, and making it standard across kind of everyone's education.
Okay. Thank you. I'm gonna stop you there, although I know, like you said, there's so many things that you can point out in it. I'm going to toss out one last question, and this is going to go to the group. And given our time restraints, because I would love to, if we do have time for questions, I would love to take some questions. And the question I'll throw out is: imagine you and your community have the care you need and want. What would that look like? And I think I'm going to limit the word count on this. So I'm just making this up as I go along. So I'm going to say you can describe this in 1 to 5 words. And if you break the rules, you break the rules. I think all 3 of you are slight rule breakers. So go ahead. Laura, you're warmed up. You go first.
Kind and compassionate.
Kind and compassionate. Leslie.
Well, as the queen of rainbow seniors, money for good care, intergenerational housing with queer trans youth and rainbow seniors, and see ourselves reflected in how things are done. Like not about us, without us. So we are part of all the planning because it's our lives, and just setting up a foundation to improve and save our lives.
Amazing. And Chase, I saw you counting.
I was counting, yes, yeah. So that's confirmation evidence that I'm not stealing from Leslie this time, but from before. Leslie, you mentioned it earlier, nothing about me without me. So if I had to pick it, I would say nothing about me without me.
Well said. Well said by the whole panel. I'm just looking to see. Here's a question from the question and answer, and I'm reading these for the first time here, so I'm just going to take it in. The participant says, "This is such a great conversation. I know Women's College Hospital does a lot of work in the transition-related surgery field. How does a trans person access care when they might live far away? Are resources in place to connect them with a physician who knows how to deal with gender-affirming care?" Now, that's a tough question. Some of those answers I think are framed and some aren't. I can weigh in a bit. Laura, do you want to weigh in maybe as well from your role as a family physician?
Sure. I mean, I can't speak specifically about the transition-related surgery program and all the specifics of the resources that they have. But I think the question gets at a bigger kind of issue that we brought up about access to care, and surgeries is kind of one part of someone's transition, if that's part of their transition goals, but that need for that primary care, which needs a lot of work in terms of connecting patients with primary care in order to access surgeries. And so I don't know if I have a great answer per se to the question, but that we do need to kind of obviously overall improve access to primary care, and perhaps find ways of integrating patients or connecting patients with primary care who are coming into the TRS program with primary care in some way. And it's obviously we're a large family medicine crisis in general, let alone in terms of access to also for trans affirming care. And I'm welcome.
Chase, did you have a comment?
Yeah, I just love to highlight some available resources, which I think will be shared in the follow-up, the Rainbow Health Ontario as an online resource, and then specifically eConsult. So eConsult is so good and it just keeps getting better. And there are some trans health experts who are like an hour or so response away for family docs who are maybe unsure, not kind of on the fence about what to do, that they could easily reach out and have accessible consultation so that they can support the care. I think the bigger piece, and I want to be short about it, but part of the challenge is addressing poor health practitioners as really flawed, vulnerable humans with feelings and insecurities. Because I don't know if you've ever met a doctor, but a lot of us are really wounded animals who became doctors to meet other needs. And so I'm sure no one on the call can relate to that. And I think that because of that, when someone asks a question, a physician doesn't know what to do, their options are to like fight or flee or like kind of hot potato it. And so thinking about the how feels very important to me. It ought not be a trans person, for example, their job to like coddle their family doctor. That's not great. And I think there's a how that can really shift the process so that the physician feels included and like keen to support and not cornered. And so maybe that's a whole other conversation. Again, it ought not be patients' job to take care of their doctors. And I think there's a reality here that that when people aren't equipped and they feel incompetent, everyone suffers. And so finding a way to sort of support everybody to like up level feels really important. And I'll just make a plug for hormones across the board. So I don't know if there are any perimenopausal menstruators on the call that, oh my goodness, if only family physicians weren't afraid of hormones and used evidence from like 20 or 30 years ago. So we all have work to do to grow. So my short answer is e-consult and kindness. Thanks.
Thank you, Chase. And I'll throw in, I mean, in terms of transition-related surgery, we know it's a challenge across the whole country. In fact, when Women's College Hospital is the first publicly funded hospital that offered a transition-related surgery program, and we had to train folks up because there are also so few surgeons who are trained to provide this care and do this work. And right now in Canada, there's surgeries offered in British Columbia, here at Women's College Hospital, and at the private clinic in Montreal, and then some other private clinics that do upper surgeries. And so there's very limited capacity. We know that we've had long wait times. We've done a huge amount of work, and the wait times have decreased significantly. There's still a lot more work to do, and there's still a lot more building of program. So, you know, there's top surgery and there's lower surgeries. At Women's, we only do, well, we do a number of surgeries, but we don't, for example, do phalloplasty. We do vaginoplasty, metoioplasty, and some other services. But part of it is building these programs. And right now, because there has to be a certain level of volumes to have competency, those programs don't exist in more rural locations and different provinces, and folks do have to come. We're an Ontario-based program with very limited funding, and so you know, we have to consider those aspects when people are seeking care who live far away. They are having to travel, they're having to think about out-of-pocket costs to stay. There are some even out-of-pocket costs for particular surgeries. So all of these things are factors, and we are advocating for resources to be in place so that people can have access to better care. But it certainly is a long journey and a work in progress. We are 1 minute to go. I would love to share more. There are going to be resources from this call that will be shared to all of the participants. And I can see in the chat that some other folks have included their own resources here for specific medical education pieces, so we'll include those as well. I want to thank you so much to the panelists who brought their wisdom and expertise and humility and honesty to this conversation, and also for the advocacy work you each do in your own realms and dimensions. So grateful for that. And thank you to all of the folks who called in the audience. I didn't get to see you. I wish I did. And let's keep this conversation going. We're just scratching the surface. Thank you.
Happy Pride.
Happy Pride.
Thank you.